I'd like to welcome all of you to our joint speaker series. We have us joining us today, Dr. Spiegel. Dr. Spiegel is a physician by training and is internationally recognized for his research on preventing and responding to complex humanitarian emergencies. Before becoming Center for Humanitarian Health Director, Paul was Deputy Director um, of the Division of Program Management and Support Services for the United Nations High Commissioner for Refugees. And prior to joining the UN in 2002, Paul worked as a medical epidemiologist in the International Emergency and Refugee Health Branch at the CDC. And he also worked as a medical coordinator with Médecins Sans Frontières and Médecins du Monde in refugee emergencies, as well as a consultant for numerous organizations. So thank you so much for joining us here today. I'd love to hear from you on just the center in general, the Center for Humanitarian Health, and your role within that center at Johns Hopkins
Sure.
to start us off.
Great. Well, thank you. Thanks for the invitation. And yeah, I'm a Canadian physician epidemiologist, and I did my MPH and my preventive medicine residency here at Hopkins many years ago. I remember Jean from back then, I believe. And then I've been away for a long time, and I came back about 6.5 years now. And so the Center for Humanitarian Health is a center that is part of the School of Medicine, Nursing, and Public Health, based in the Department of International Health. And it's a center that, as one would imagine, it does a mixture of research, a lot of teaching and training, and more evidence-based advocacy, specifically on crises throughout the world, and also what's been happening on the US-Mexican border. We're about 12 or so core faculty, and then we have another, in total, approximately 50 faculty throughout the three schools. And we have been focusing primarily on conflict and conflict-related issues, but we do have a bunch of colleagues who are working on natural disasters. And we are expanding, as I guess the world is, into the climate change, climate emergency, and also, which I didn't anticipate, is expanding into migration beyond forced migration. It was already happening before, but particularly with what happened in terms of Title 42, and we can talk about Title 42 for those who are not familiar, from the CDC declaration. And then what happened at the border under the Trump administration currently is happening still. We've become much more involved in economic migration, and particularly undocumented migrants.
Wonderful. And I don't know if there are any particular activities from the center that are ongoing that you'd like to highlight, or specific projects.
Yeah. So it is quite broad, and what we have is, I'm just going to bring up so I can see it. There we go. Excuse me. We have, let's say, our broad areas are, we have a large group working on mental health, a large group working on health systems. I'm thinking of the broad areas, a lot on surveillance, monitoring, and evaluation, and all of these relate to humanitarian settings. And so what we always try to do is understand and work with others who are working in non-humanitarian settings, and then try to understand and apply the different methodologies. We also, another large group, not large group, a specific group, are working on epidemics in humanitarian settings. We've been working on various projects in cholera and Ebola, and of course, COVID. And then another large area is looking at food insecurity and drought. And then there's a group looking at intimate partner, sexual, gender-based violence, and other forms of the violence, and then related to sexual and reproductive health rights. So those are some of the very broad areas. I must say we've been dealing with on and off with some groups of with surgeons, and we have previously we had someone, I'm just trying to remember his name, was when I first came here, who is a surgeon but is no longer practicing. He now lives in Alaska, and he was working with us at the beginning, and he was on an area that I'll eventually talk to today on Mosul and the Mosul trauma response. And his name will come to me in a second. I'm just having a blank.
Is it Adam Kushner?
That's it. Yep, Adam. And we do receive a lot of there. I've had a couple other surgeons that I've spoken to at Hopkins over the years, and there is a global surgery group. There's a person on our advisory committee. I'm going to have a lot of mental blocks, so he'll also come to me in a second. He's an older fellow. He's now, I think, in his late 80s, early 90s, who still does surgery, and does surgery, but mostly he's a mentor, of course, at this point. And he does a lot of trips abroad, and his name will come to me shortly. And we often talk about surgery and global surgery, but we have not yet, or at least we haven't been able to make the connections within Hopkins as in some other areas, because there's, on the Mosul response, we did work with a surgeon that is working in more conflict zones at Stanford, and we had a resident who was here with us for a while, and now he ended up going to UCLA, and he's continued on in looking at surgery in conflict settings. So those are mostly in our large research areas. I didn't mention also maternal child health is a very big area. And then in terms of teaching, we have at the School of Public Health, we have a humanitarian health concentration and a certificate, which is quite popular. We generally have between 30 to 40 people a year doing that mixture of MPH and MSPH. We generally have one or two, and now it's usually one PhD student focusing on humanitarian health, and a bunch of other DRPH students. And we do have courses that may be of interest to some of you, which is Gilbert Burnham and Maya Vevers do a health, it's called Health Emergencies in Large Populations. It's a used to be 3-week course in winter or in the summer, and 2 weeks in winter. I believe it now is 2 weeks across the board. But a lot of people do that. It's an intensive and very both technical, but also a lot of operational and application of humanitarian emergencies. It's almost like a consolidated course over a short period of time of the broad issues, everything from protection, human rights, and humanitarian principles, to all the key areas of WASH, healthcare, nutrition, etc. So that's a course that I think a lot of people benefit from, and it's in conjunction with ICRC, the International Committee for the Red Cross, and WHO.
Wow, that sounds like a really comprehensive class.
It's quite good. And all of this, maybe I can even share eventually with you, share my screen and show you some of the center of the website. And we have a list of all our projects and all the various trainings as well.
Wow, clearly very, very interdisciplinary as far as the work that the Center for Humanitarian Health does. Maybe before we turn to the Mosul response, or sort of unpacking a little bit about some of your thoughts and reflections on, the role of emergency care and surgery in this space, would be curious as a trainee myself, sort of how your journey evolved in this space, and if you knew from the time you were in medical school that you wanted to get involved in the humanitarian space, or if that was something that you learned along the way or sort of discovered later in your training, and then how you would just sort of maybe recommend folks today, or anyone on this call, mindful that we have a number of trainees with us, to sort of get involved, or at least start thinking about how to get involved in that space.
Sure. And I see Kent. Kent, I remember we met early on, and I'm still not giving up and trying to see if there's a way that we can get emergency and surgical either residents and trainees and do something within the humanitarian space.
Most definitely. We actually are doing a little work in that space, and probably should update you at some point.
Great.
But we, again, appreciate you being here today. Thank you.
Oh, no, it's a pleasure. And same with you, Bhakti. I mean, we had strong ties originally with the emergency medicine group, and those have, because there's been a lot of changes. And so in the School of Medicine, we now are working more closely with a lot of the infectious disease folks there. But we still would like to. In terms of the Center for Humanitarian Health, I feel, being here now 6.5 years, that it's still too School of Public Health focused, and we want to re-engage with the School of Medicine. We have quite strong relationships with the School of Nursing, and then I didn't mention, but with 555 Pennsylvania Avenue, the museum that will now be Hopkins in Washington, we are also hoping to develop further ties with SAIS, because political science and humanitarian health, it's they're so intertwined. So our goal, and as we look at migration as well as climate change, really is to become more inter-Hopkins schools than we actually are at present.
We agree completely. I think there's some interesting collaborations already forming between emergency medicine and surgery. Kent and I were both honored to be at the WHO Global Alliance for the Care of the Injured meeting recently. And I do think the idea of trainees being able to join humanitarian response activities is definitely feasible. Now we've got over the burden of COVID. Trying to provide safe opportunities for emergency residents as well as medical students is definitely more feasible. So we should try and connect, but we want to know, I think, a lot about how did you get to where you were? Like most of the people on this call, that you joined the UN, you worked through a number of different agencies, both governmental and international NGOs. So how did you shift from the clinical to the public health work, and how do you maintain the balance?
Sure. Yeah, and so Alex had asked that as well. So I'll get into that now. I would say most people, but I was not one of them, fall into this. They're interested, and somehow they just, it wasn't planned. But for me, it was planned somehow. When I was really young, I think I was maybe 13, 14, I was reading Time magazine, and I saw this French doctor on the Thai-Cambodian border, and I thought, that's really interesting. That's what I want to do. So I went into medical school with that in mind, without having any idea how I would go about doing that. But my undergrad, I did political science, because that was always my interest, and I wanted to do the prereqs for medicine, but continue with political science. And so there is that aspect of politics and humanitarianism, and then medicine, that's always been throughout. And then, this was a long time ago, and so there weren't the options that we had now. And so I did. I finished, during medical school, there was a tropical medicine doctor who was quite well known in Toronto called Jay Keystone. So he was able to, early on during my medical career, during my studies, medical school, I spent time, not in humanitarian, but I spent a summer in Kenya and a summer in India. And that was really helpful for me to at least better understand what it was like to work in those areas. And then was, in those days, you could actually get your medical degree and get licensed after 1 year of medical internship, and then you still could do a residency, but you were licensed. Yeah, it was the Wild West then, I'll tell you. So what I did is, after my first year of residency in internal medicine, I left. I took a year off, and I went with Médecins Sans Frontières. Then it was with Canada, and we were working with and still are, with the Dutch MSF group. And that was incredible, because you can't probably do it now. Then it was still whoever wanted to volunteer, and if you had some experience, or even if you didn't, you just went. It's not like that anymore. Probably that's a good thing. So but I was able to go, and at that time it was in Kakuma refugee camp. It was just opened. Sadly, it's still there. It's with the South Sudanese Lost Boys and others who came over from South Sudan, Ethiopia, and then fled Ethiopia through Kenya, into Kenya. And it was very intense, and I was really not well prepared at all. And I've seen this a lot with people in the humanitarian field as they go, and probably 9/10, maybe even more. They have an experience, whether it be with a mission, a religious mission, or a mission with MSF or these others, and then they say, this is really interesting, but it's not for me. And then there's that fewer percent that say, I want to make this my life, your life, what life's work. And that's what I decided to do, but also to try to professionalize it, because there was some pretty traumatic events that I was exposed to more as a physician, but feeling unprepared, and then feeling guilt that I should have done better if I was better prepared. So after that experience, I went back to Toronto, but there was not a Center for Humanitarian Health at that point. And the only way I was told that I could have a career in this sort of career was to continue on with internal medicine and then do specialty in tropical medicine, and it would be another 10 years or 8 years, 7 years. And I didn't want that. I knew that if I did that, I would get caught up and never leave Toronto. So I did something that I don't recommend, and everyone told me not to do it, but I was quite unhappy because I knew I wanted to be back in the field. So I actually quit internal medicine, yet I was still licensed, and I worked in an emergency room, being supervised by senior doctors for a while. But as soon as I could, I left again, and I went for a couple of years. I worked in Russia. I worked in post Rwanda genocide. But I neglected to say one thing before I left. Luckily, one of my Toronto internal medicine faculty who said, I really think you need to go to Johns Hopkins to get an MPH, because that's what I did. And then I've come back, and it really was life-changing. So I did that after working a few more years in the field. And so I stopped clinical medicine at that point and went to Hopkins and did a preventive medicine. But I wasn't one of those people that didn't like clinical medicine. I liked it a lot. And, I still, whenever you are in the middle of nowhere, you still do small little things for people that are in the field. But I felt I couldn't do both and do both well. And I didn't want to. And this is, I think, where it may be difficult for a lot of people that want to really make a career of this, to go into the field for a couple of weeks at a time is very different than spending years in the field working. And I think a lot of surgeons and emergency medicine people do, which I think is also great, is they work hard, especially emerge folks, because they can work hard and then spend X amount of months and then try to go into the field. But it's very hard to be able to continue to do both. It's possible for sure, but it's even more difficult if you eventually want to work with some of the larger NGOs, or you want to work with the UN, because we're at a point now where we're not practitioners. I'm not a practitioner, a health practitioner in terms from a clinical point of view. Where I work, I'm not needed to do that, and it would be, it would be almost paternalistic at this point. Maybe not for certain surgeries and other areas where there are some unique aspects, but generally now, what I did when I was with the UNHCR is I would run emergencies, and it would be everything from strategy, policy, and then coordination. But you have the national NGOs more and more who have the capacities and are doing these things, actually doing the work. And so this role of a humanitarian, and what we did when I first started about 20 something years ago, 1992, is very different now. And our role in the future will be quite different, because of this issue where there's so much more capacity. And I think we're all trying to figure out what our roles will be longer term in terms of what the United Nations roles will be, and international NGOs, as country capacities improve and we're not needed in the same way. I'll stop there, but happy to answer questions or comments before Mosul. That was a lot to take in.
So any other questions from the audience about career, the Center for Humanitarian Response, how you can get involved?
Yeah, don't quit your residency. That's definitely, I'm reading the thing.
I told
Just
Dr.
making sure.
Hensodi, I think medical student loans will prevent all of us from doing that.
See? In fact,
But
there
that
were a couple different things. Don't quit your residency. I'm happy I did, but that worked out well for me. It's not going to work out well for most. But also that's a big difference, is that I, as a Canadian, or most Europeans, don't come out with massive student loans. So there are many more humanity. It's much easier for me. When I worked with MSF, I was getting $1,000 a month. And that was fine because I didn't have any student loans. And so it is a very different situation.
no, that's
Can
It's
I ask Paul?
it's really an intelligent comment, Paul. I think that's really true, right? I think that many of our students in this country are kind of hamstringed, right? They can't really move. And doing what you did, or John Tarpley, John, who just moved to Africa right after his residency, that's not really as feasible for many or most of our students. So I do have one follow-up question, just a personal interest. A lot of the people who are successful in your sphere, as you, have completely left clinical medicine. And when I think about my mentors like Charlie Mock and whatnot, and it is hard to juggle both. And I just want to make that, I think some people, we like me, kind of fake it a little bit, but I think Dr. Spiegel's point is well taken, is that I appreciate you jumped in, and that's what you have to do sometime. But
yeah, maybe just to follow up on some of that, is that it ultimately depends on what you want to do. And there's a whole other aspect, especially in the humanitarian field, that you have to recognize, is that is the personal life. So, I married late. I married when I was 40, and I spent most of and it was a deliberate or not, I was very focused. I wanted to spend time, what we call in the field. And there was no way you could do that with a young family, or at least it's very difficult to do that. And I spent 15 years at UNHCR. The divorce rate at HCR is, I don't know if it's really true, but everyone says it's very, very high, 70 or 80%, because you're moving around constantly, and you have in a lot of non-family duty stations, and it's generally 2 to 3 years at a time. It's not the case with WHO, which is one of the reasons why WHO is slow and bureaucratic, because people stay there forever, but at headquarters, let's say. But for most of us, you move around, and so it's a great life when you're younger. It's certainly possible when you're older, but what I find consistently with some of the older students that I'm training, many of whom are doctors, and they're taking the humanitarian health, they don't have the personal ability, let's say. Their family situation doesn't allow them to really go into the field and spend a lot of time. And it's hard to be a humanitarian if you haven't spent a humanitarian, when I mean, humanitarian working for NGOs and UN, if you haven't spent time in the field and you spent most of your time in Washington or Baltimore.
Paul, as a fellow faker, now like a mom of 2 children, so traveling is really challenging. I have to persuade my husband, and I do overnight flights and try and assume care on the weekends. One thing that strikes me is when I was young and enthusiastic, I remember seeing the Haiti earthquake, and now I see the war in Ukraine, and I'm like, I want to do something, right? And I hear that sentiment echo among my junior colleagues. Can you please talk a little bit about what is the right role for a clinician during an acute humanitarian response? And is it a role in the acute phase of the response? Another thing that we saw a lot after Haiti was that, feet first approach to providing support meant that critical resources were being taken away from the first responders who were really trying to provide the public health response. So since there's a higher number of clinicians here, can we talk about the role of clinicians in an acute phase response?
Yeah, great question. Number one is I realize how much older I am than you. For you, it's Haiti. For me, it's Rwanda, 1994. But what's I'm going to get there, but I want to explain one thing. So now, the Center for Humanitarian Health, we have an advisory committee. It's still very hard for people to say, when Ukraine happens or the Turkey earthquake, they want to know, why aren't you there right now, immediately, our advisory committee. And I personally, I love being there because that's what I did in the past. So my first 4 years here, I didn't. And now what I'm able to do, and my wife does the same thing as I do. So she actually understands and it's no problem. So I'm now, what I've been able to do, which just has put so much life back into me, is I'm able to quickly respond. So I went when in November, December 2022, when the Taliban took over, I went for WHO and I ran their response in there. And I went for Ukraine, where I ran their refugee response in the outside areas. That's wonderful. And it makes it, I love doing that because it's very operational. But number one is, I can do that because of the years of experience I had before. Most academics that are working here, at least even in the center, aren't able to do that because that's not what their role is, and they haven't really done that. Number one. Number two is why I'm also saying that is because in Ukraine and most recently in Turkey, you don't, for most young doctors who don't have humanitarian experience, and haven't worked in these contexts before, the best thing is not to do, the best thing, but the hardest thing is to do nothing, is not to actually go there, because most likely you'll be a nuisance, because the space, particularly at the beginning, whether it be an earthquake or whether there's been a massive population movement, the humanitarian space is quite limited, and we need professionals there who really know what they're doing and who understand the coordination system. And following the Haiti earthquake, there was a massive change into what was then foreign medical teams, which are now emergency medical teams, to restrict what was happening, because you had a free-for-all of so many mom and pop people going in and groups going in that made Haiti a mess and did a lot of inappropriate things. So now it's really important to restrict. And then the other issue is, so what do you do? And this is also hard for people, because even if you want to do something, so I had my niece who was going around for the Turkey earthquake and trying to gather as much goods, working with the Turkish embassy, and then wanting to send material goods. Don't do that either, because most of that is either not needed, it's way too expensive, it's taking so much people's time, and then half of the goods that come there are either inappropriate, particularly if they're medications, they may not be the appropriate type. So there are now, the best thing to do is to choose an organization that you like, that you trust, and then send money to them and let them do it. That's really hard for a lot of people to hear, I think, because it's difficult. And I want to just end this one by saying, if you get the chance, on the CHH website under our events, 3 weeks ago or 2 weeks ago, we had an incredible and very emotional seminar where we had a vascular surgeon who is based in Michigan, who's from Syria originally. And he happened to be working with Gilbert Burnham, one of our professors here. So he was in Gaziantep on a completely unrelated project. And he was there when everything happened. And he talks about his story of what happened at the beginning, first when he realized he wasn't going to die, and how he wanted to use his skills and was walking around Gaziantep trying to figure out what he could do. And because it was Turkey and the language was completely different, he couldn't do anything. And he realized, actually, even though he is prepared and he's worked in Syria in these situations, he couldn't even do it because he wasn't with a proper group, and there were language and other issues. So maybe just as an FYI, it was a really powerful event. And it was just interesting to see someone who actually did have the proper skills and has worked in that context before, albeit not in Turkey. And he realized that he was useless in that situation, sadly.
I appreciate you being realistic with us. It's helpful to have that insight into what support we should be providing.
But
Yeah, I don't know what anybody else's mothers told them, but my mom always said the road to hell is paved with good intentions.
Yeah.
And clinicians have a lot of great intentions.
So
there is, if I can, I mean, there are a lot of things that you can do and think about. I mean, the other thing is, a lot of people, and many, and I'm assuming many of you that are actually practicing, is you don't necessarily need to be going and doing surgery or doing emergency medicine in these areas. Surgery can be slightly different depending on what you're doing, but what I'm getting as the other way that a lot of people do this is then they work on research in other areas, which is you're not necessarily a practitioner, but you're doing more research into global surgery, into emergency medicine, which is hugely important. And that's where I think many people who aren't able to, let's say, devote 10 years of their life in the field as a practitioner, but who come up through and spend time, months or weeks in the field, this is often what they're doing. And I'm assuming back to Kent, that's often what you're doing as well. So there is definitely a career there, but even that career is changing in my view, because both, with the decolonialization, with the paternalistic way that Hopkins and others are quite good at doing, we need to really think differently and try to move our relationships and research into a much more equal way. And I'm in a bunch of projects right now, and it's really challenging to be able to do that. It's so much easier to just give lip service to it, but then have the people who you're doing research with tell them what to do, as opposed to actually working together with them. It's very challenging, which is a whole other challenge in our field.
So, Paul, we don't actually have to move on to the case study if this is an interesting discussion, which I believe it is. Can I get a thumbs up or thumbs down from the audience? Thumbs up if you would like to move on to the Mosul case study, which is very interesting and kind of gives you a real life example of some of the themes that we've talked about. And if not, we have some questions in the chat about Dr. Siegel's career.
And the other thing is I have it somewhere, but we have this lecture or this discussion on Mosul taped, so I can share that with you, and you can watch it another time if you prefer. I'm completely.
Let's do that, because I have some really interesting questions here. And so one thing Brent Lee is asking is, can you talk about your work at CDC? He said, and Brent, feel free to come off mute and just ask the question yourself. Otherwise, I could relay it for you.
No, I'm right here. No, I was actually an epidemic intelligence officer there, and it was just great experience. I was probably about 70% of my work there for 2 years. I was sent overseas to investigate all different epidemics and a whole bunch of other things. And so just as a suggestion for folks looking for a way to transition, I'd be curious what Dr. Spiegel would have to say about that. It's just additional skills that you don't learn in your clinical, training, but I think it's a great transition point.
Yeah. And just, everyone call me Paul. It's Kent. Brent, what were you, who were you with? Which division at that time, or which branch?
At the time, I was with the measles division at National Immunization Program, which was a bizarre place for an anesthesiologist, but I wanted the overseas experience. And, the nice thing about EIS is they second you to all. So I got sent to Office of Foreign Disasters here in Washington for 6 weeks. I got put on a landmine injury project in Ethiopia. And then I just happened to be, during 9/11, sent to do bioterrorism surveillance when the planes crashed.
Wow, that's great. I mean, EIS absolutely is one of the best training grounds for, let's say getting an MPH and then going to EIS, or even if you don't have an MPH and you can get into EIS, it's spectacular because it is practical training. And yes, I would say my only concern, so I'm very pro EIS and very pro CDC. They're a great, it's a great organization. A couple things have happened over the time. When I was there, I was at what's called the Emergency Refugee Health Branch, and there were about 10 of us, and we, come in with jeans and Birkenstocks, and no one gave a damn about us. No one knew what we were doing. We could travel wherever we went. We went to crazy places, and no one just knew. Now it's become much more bureaucratic, CDC, particularly overseas work and emergency work, with reason, because becoming a hostage or getting kidnapped is a concern, and therefore what's happening. My wife is Hopkins, but she's 80, it's now I think 70% CDC at my old branch, which is now called I think the International Emergency Branch, IEH Health Branch. And it's really difficult to travel to most places. 3 weeks ago, I was in Mali, and Mali's a dangerous place, but met all the CDC and other folks. They can just stay in the US Embassy, and then they can go to one other place and that's just in Bamako. You can't go outside. So it has become very, from the emergency health humanitarian, CDC has become a difficult place to work in terms of that aspect, in terms of security. But EIS in general is one of the best trainings. Yeah, you can have, and you learn so much. And I think that gives you a great, especially if you can spend time abroad, it gives you an incredible expertise. How are you, Brent? Now you're doing what, anesthesiology still, or you're finished?
Yeah, no, I went back to private practice. I do patient safety work, but considering sort of a transition, actually more working in biodefense now.
Oh, interesting. Yeah, I mean, related, the whole issue of global health security, epidemics, pandemics, obviously is
Exactly
amazing and a growth area. So I see Zach joined. I've met Zach before as well. Yeah, so
I think one of the things to point out here is there's like so many different ways to have this hybrid career. So it's not a zero-sum game, not all or nothing. When I was making my decisions, I did a Fogey Award opposed to the EIS because I was unable to convince my spouse at the time that me being seconded to a bunch of places would be good for our marriage. And that marriage ended anyway, but that's a different story. But there's all these other life considerations that happen. But in the end, you'll probably get to where you want to be, right? So I know there's a lot of anxiety about what is the right path, but that is not what you should take away from this conversation. I'm going to ask Tegan to unmute, who's also asking, like, what is the right way to get involved? And Paul had questions in the chat for you as well. But Tegan, do you want to ask your question directly?
Yeah, sure, absolutely. I actually have a friend from medical school who is finishing her infectious disease fellowship now, who has just applied to do the EIS thing. So that's so interesting to hear it from her perspective first, to see, as she's excited she just got a call from the CDC and offered a position. So it's so interesting to see how careers are starting and shaping from that standpoint. My question was more so, how do you kind of bridge that gap from those starts in academics and in these kind of more educational positions, and make that move into becoming more of a leader position or heading a team to do response work, or kind of being the person in charge or person called upon to do that?
Yeah, good question. I think there isn't one, just like there's not, like as Bhakti said, there's not one path, and most people it's not been intentional. They just move into certain areas, etc. So it's not, but in order to be, so a lot of it depends. I mean, if you start in academia, and spend most of your time in academia and then want to move into more of a leadership position in the UN, it depends on what you're doing, or UN or some of the international NGOs. It depends on what you're doing. So for example, there's a colleague here of ours, Alan Lebrique, who, and then there was another colleague just as I got her, she left, another Canadian who took over as head of immunization at WHO, and Alan Lebrique, who was doing all digital health here, just took over as a digital health section at WHO, not humanitarian, but broader. So there are ways when you, in terms of if you are an academic and you're a leader in your field, you often start by getting on as you become better known and you get onto various committees, whether it be WHO or other organizations. UNICEF does a tremendous amount in immunization. So that's one way. In order though but they're still continuing in a technical fashion for the most part. So that's one way. But in terms of being operational and saying, I want to go run a response in Ukraine or Afghanistan, it's harder to be an academic do that. I think most of those people, let's say, that are more operational nature, started off, nearly all of us started in NGOs. And then from there, as you work more and more in the field, it's not, I don't want to think of it as an hierarchy in terms of an NGO, national NGO, then international NGO, and then the UN. But, I always say to everyone, never go to the UN at the beginning of your career, because you're just going to go there to die. And it's bureaucratic, it's stultifying, but you can have a larger influence in many ways. But to start with, if you want to be more of a practitioner, it's working with probably this, in your case, international NGOs. Sometimes it's really good with the American Red Cross, because they are also looking for people to be able to respond. Another key issues that we haven't discussed is our languages. So languages are really important. Spanish definitely can be helpful, of course, in the Americas and in some parts of, mostly in the Americas. I speak French. I'm Canadian, but that was very helpful in Africa and Central West Africa. That's important. And the UN is getting quite strict in terms of now, if you want to work with the UN, in theory, there are always exceptions to everything, but they want you to be able to speak at least one other UN recognized language, not as a consultant, but when you join. But there are exceptions. And then the other thing I would add, just to end, that is changed, is that there are too many white males in the UN, and, well, frankly, in most areas. And so, but the UN and many of the international NGOs are quite strict. So there are quotas, and or you're at a disadvantage, and I think certainly I'm okay with that, although I had the advantage previously, so it's easier for me to say I'm okay with that than maybe others. But there is really a push for much more diversity, and that's changing as well. So I think Americans, or let's say North Americans and Europeans, will have a harder time to get into, let's say, leadership positions in the UN. Here I'm talking high leadership positions, at least for another couple decades, until there has been more parity with other situations, except for the head of these UN organizations, because that's still very, a lot of it, usually, for example, the head of UNICEF, the head of World Bank is usually an American, and there they divvy up things that are according to nationalities.
I will just say, Paul, playing on that word of practitioner versus leader. So there is this misdemeanor that all of us need to become leaders, right? We have the leadership track for X and the leadership track for Y. And the truth is, when you meet the leaders in these roles, and I was at WHO just a couple of weeks ago, I got to meet the leader, and their first job, they were practitioners, right? Tedros was this junior guy at the Ethiopian Ministry of Health, plugging away, and he plugged away for 40 years until he rose to this leadership position. And so I think for all of us, we talk about colonialization as a sexy term, but we still have this focus on leadership. And I would really love to see the dialogue change to, how do I become a good practitioner? How do I become a good partner? And it's by doing that you'll grow into leadership roles. But there is a challenge when the focus seems to be on being a leader before being a practitioner. So I do think courses like the Humanitarian, help Humanitarian Assistance for Large Populations course, Harvard Humanitarian course, these courses give you insights, but then you have to transition to be able to practice the skills that you learn as the most junior person in the team, earning probably the lowest salary in the team as well, right? And then you work up the chain once you understand the dynamics of the team that you would like to lead one day.
Yeah, very much so. And I what I've noticed, and this is a bit of a generalization, but I see some of the younger generation where they want to move up too quickly, or they feel almost they deserve to move up too quickly. And you have to have a lot of patience. And then it is a mixture. Most of the leaders, whether it be Tedros or Mike Ryan and WHO and it's been a long time that they've worked in the field, and then a lot of it in those really senior positions also become very political. So, but I don't think we're talking about those senior positions. But then it's in the UN and some of the big international NGOs. A lot of it depends on government backing and other areas. But I don't think we're talking there. We're talking more in sort of senior positions where one can have an influence. Yeah,
But
please.
even to lead an effective humanitarian response,
Right.
you will have had to participate in a response several times over. And thank the Lord that there isn't that many opportunities, to really work through several responses. So time is like really the key element to many of these, opportunities.
Yeah, it's going. The other thing I think that I see people saying is, yes, I really want to go to the field, but because of this or that, I can spend 2 weeks. You need, at least when you're younger, you need to spend longer, because then, and not because it is in any situation, it takes time to understand the situation. It takes time to understand the situation, the culture. Now I can go in quickly because I've been doing it for 30 years, so I can respond in a 6-week period, but I'm filling a gap until we can get the others that are going to stay there for a year or two. And that's hard because I know you're all doing your residencies, but the other thing I don't know if it's feasible in various residencies, but are you able to, does Hopkins in your residencies, are you able to do any rotations abroad? That's huge. And that's what I started to do in medical school because that's what I knew I wanted to do. And that also just is very helpful.
The purpose of the Paul Lietman Fellowship is for 6-week rotations abroad. You can work with your leadership if you're not getting that time. I have a second hat, which is the Associate Director of the Center for Global Health. That is my job, is to talk to your program directors, right? So please reach out to me if you're struggling to get time to do clinical electives, and we will be your advocates. Paul, there's a question in the chat from Habab, who is a colleague from South Sudan, who's joining this talk, asking, is there opportunities perhaps for non-Hopkins colleagues to participate in activities at the center?
The answer is yes, but it's harder. And the reason is we have so few opportunities for research and particularly for travel into the field that we prioritize Hopkins students just because they're here and they're working with us. And in some ways, whether right or wrong, we feel that they should have the first chance. And our research often, it's very hard. It's more challenging to get 5-year NIH grants. So we're often working with Gates Foundation or previously OFDA, now Bureau for Humanitarian Affairs. So they're often 1-year grants. And more we're working in areas where it's very difficult to bring students because of the security risks. And so we really have to work hard, but we're getting there. We have a bunch of students that were in DRC, a bunch of students that actually, to my surprise, did go to Mali and Bamako, bunch that went, which is not nearly as dangerous, but in different parts of Pakistan. So because of the limitations of that, and unlike in some of the more calmer situations with large scale NIH grants, we're not able to say, okay, we're going to have a rotation every year in Somalia. We're not able to do that. So that's why it makes it a bit more difficult for non-Hopkins students.
And so global health is really dynamic, right? So the way that faculty support trainees to participate in global health experiences is through like our grant funding, some philanthropic funding, and then long established relationships. But projects and project needs constantly change. We work on 6-monthly cycles. So unless you're doing established clinical rotation, which is extremely challenging to fund, but we do have Paul Lietman funding for house staff, you have to see what's available in terms of projects. A really great resource, which I'll ask someone to put into the chat, is if you look at the Global Health Established Field Placements Program, which is through the Center for Global Health, that has a list of all the faculty and all the active projects. And you can always contact those faculty and say, hey, do you have room for one more person? Can I participate in this project? And I think the answer is often going to be yes. Any last questions for Dr. Spiegel, except for when you quit your residency, what do you do with your student loans? Because he doesn't know the answer to that.
Don't quit your residency. It wasn't my goal. The other thing, though, that we do look for is everyone should think about, I'm looking at the time, yeah, their comparative advantage. So, for example, we do a lot of work in certain countries. So we often will look for French speakers, or we do a lot of work in Congo. So if someone is Congolese and, you know, at the school, we'll often, there's often opportunities. So it also relates to that in terms of language and context and cultural background. So this is the center's website. This is the help course that you can check out. I don't know how it works, let's say with the residencies, but normally you can take it for credit, but you can also take it without credit. It is, I think, the best intense course that you can take in terms of really trying to understand the humanitarian dynamic. The other area I think that's really important for you is to look at our ongoing projects. There. So here we have, for example, strategies to maintain health delivery for in and out of camp settlement and refugee populations. This is something I'm working on COVID-19, but you can go through these. This is another really interesting one on Ready with Save the Children. And then when you go in to read more, you can then find out who is here for this one, the faculty lead, a little bit about it, and then you can contact the lead, and it gives you a little bit more information. So a lot of the students do go on to look at areas where HEAL is another great, this is actually the School of Medicine with Nick Cunha, who's doing asylum work. And they're always looking, by the way, for physicians. I'm even volunteering to document people who are seeking asylum in the US to do medical and other exams. So this is, I think, an interesting aspect of the site. The other aspect are some of our resources, and in particular, you know, we have tools and guidance, but we try to keep our reports. Let's see if we get, yeah. So more reports are coming out all the time. So this is something that just came out this past month, where we did a large biobehavioral survey of HIV and syphilis amongst Venezuelans in Colombia. This is a report that also came out 2 weeks ago on looking at cholera, and this is actually looking at the humanitarian system and how poorly it is doing in terms of how we are responding to cholera. So there's a bunch here that you can feel free to look at. And I will, yeah, maybe just end by saying we do have, if you're interested, we have a mailing where we give the updates. I can stop the share. I'll just show you that and then I will stop. We give updates of what's happening. So you can join, and then there's we do job postings. There's a weekly newsletter that also provides postings. And then we do seminar events, and used to be Humanitarian Health Digest. We've stopped that. So, voila, it was really nice to meet you, and feel free to reach out. I'm traveling a tremendous amount, so I sometimes don't get to my emails. I'm going again tomorrow night, but it's a pleasure to meet you. And looking at Bhakti and Kent in particular, I'd really love us to figure out a way that we can re-engage both in teaching and then also some sort of joint research as we move forward.
Let's make it happen.
Yeah, expect an email when you're back from travels with a meeting request. So we'll be there.
With pleasure.
So Paul, it's just always an honor. We're so lucky at Hopkins. I remember when the Center for Humanitarian Health was first formed, and we were so excited that you were coming. And it's just wonderful to see someone with such rich experience really helping shape our footprint in this particular area of work. So thank you so much for joining, being so humble, and talking us through some of the nuances of balancing a humanitarian response career and a clinical career, less of the balance, I suppose. But it was really nice to hear about your journey.
We appreciate it. Thank you for having me speak, and yeah, good luck, and please feel free to reach out, everyone.
Safe travels.
Cheers. Bye-bye.